Okay, we're going to begin talking about some of the different endocrine organs. We're going to start kind of at the top of the body, work our way down. So the first organ that I really want to focus on is the pituitary gland. And the pituitary gland is, you'll remember, a gland that is dependent or it hangs off of a larger gland inside of the brain called the hypothalamus. So if we're looking at the interior of the brain, the hypothalamus is located in this region. There's a little stalk called the infundibulum that connects the hypothalamus with the pituitary gland, which sits immediately below. And you can see that in a larger drawing over here. And the pituitary gland, as you'll remember, has an anterior portion and a posterior portion. I'll discuss that in a minute. But before I do that, let me just briefly remind you about the hypothalamus and its role as an endocrine gland. The hypothalamus is neuronal tissue. Its main duty is to maintain various types of homeostasis. So that homeostasis, wow, I don't know why it was doing that. But anyway, that homeostasis varies from things like regulating sensation of thirst and hunger. It helps with mood, helps with manufacture of everything from breast milk to helping an individual grow through the production, or the release of growth hormone. So it has a lot of important duties for the body. And it manufactures a number of hormones which it releases, and these hormones then travel to specifically the anterior pituitary. And those include growth hormone releasing hormone and growth hormone inhibiting hormone, prolactin releasing factor and prolactin inhibiting factor, which is the same as dopamine. Prolactin releasing factor encourages the release of prolactin. Prolactin stimulates breast milk manufacture. Gonadotropin releasing hormone, which stimulates the release of luteinizing hormone and follicle stimulating hormone, both of which are necessary for proper egg and sperm development. Thyrotropin releasing hormone, which stimulates release of something called TSH, which then stimulates the release of thyroid hormone, and thyroid hormone is important for many metabolic activities in the body. And corticotropin releasing hormone, which stimulates the release of ACTH, which then in turn stimulates the adrenal cortex to release a number of different hormones such as glucocorticoids, corticosteroids, etc., that help regulate things like sugar levels in the blood and are important in the stress response. So don't forget that the hypothalamus actually commands what the anterior pituitary does. It does not have any impact, it doesn't impact the posterior pituitary in the same way, in that in the posterior pituitary, rather than having hormones travel down from the hypothalamus into the anterior pituitary, in the posterior pituitary, action potentials induce the release of different types of hormones, the two being oxytocin and ADH. So let's look at the pituitary gland itself and the kinds of problems that can arise in the pituitary gland. And this is true of all types of endocrine gland disorders. You can have disorders that result from overproduction of hormones from that gland, or you can have problems that result from underproduction of hormones from that gland. So we're going to look at the pituitary gland. We're going to tackle overproduction problems first, and then we'll discuss underproduction problems. So hyperpituitarism is a condition wherein you have overproduction of one or more hormones in the pituitary. And notice I said one or more hormones. The pituitary gland releases a number of different hormones. And so you can have only one hormone being overproduced. You could have multiple hormones being overproduced. So the typical, most common means by which I get hyperpituitarianism is through an adenoma. And an adenoma is basically a cancerous tissue that has developed in the anterior pituitary. Adenomas relate to epithelial tissue, and remember, the anterior pituitary is indeed made of epithelial tissue. That's where it actually arose from tissue in your throat during embryonic development. It's not neuronal tissue. And we can classify these different types of adenomas based on the type of hormone that gets produced. Again, as I said, the pituitary manufactures lots of different types of hormones. So usually adenomas secrete only one type of hormones, but sometimes it can secrete two. For example, a common pairing is growth hormone and prolactin, both released together. And adenomas can be of one of three varieties beyond, after you've decided which type of hormone they release. There's also another way we can identify or type the adenomas. They can either be functional, silent, or hormone negative. A functional adenoma is one in which the hormone that's being overproduced causes some sort of clinical effect in the patient. So we start to see signs and symptoms that indicate that we have overexpression of a particular hormone. That's a functional adenoma. A silent adenoma, as the name implies, is one wherein, we're getting overproduction of a particular hormone, but we're not seeing clinical effects demonstrated in the patient. And then the third of the three types of adenomas is a hormone negative one, and that is where you don't have any hormone detected, even though there's cancerous tissue that's present in that area. Now, what are some of the clinical manifestations of hyperpituitarianism? One of the biggies is something called mass effects. If you think about, and let me back up to show you here, the location of the pituitary gland right here in the brain. If I have a region of overgrowth of tissue because of an adenoma, the brain is housed inside this rigid case called the cranium. And if I start to increase the size of any particular region in that brain, it's going to necessarily impact other regions of the brain by putting excess pressure on it. And that's what a mass effect is. And it happens that the hypothalamus and the pituitary are located very close to the optic nerve and the optic chiasm. And as a result, you can get what's called optic chiasm impingement. Optic chiasm, remember, is the point where the optic nerves cross over each other, left and right cross over, on their way back to the occipital lobe. And so if I get impingement on the optic chiasm, of course, the clinical manifestation a patient would notice is some sort of visual disturbance. They're not seeing as clearly. They have a grayness to the edges of their vision, perhaps. These can be an indicator of some sort of a tumor present in the brain. Now, sometimes also, because there are cranial nerves nearby, sometimes the manner of growth of that adenoma can impinge on a particular cranial nerve. And then, of course, you remember from Bio 201, each cranial nerve has different responsibilities and functions. So depending on which one gets pinched or impinged upon, you can have a variety of different clinical manifestations as a result. Other types of clinical manifestations are obviously that if I have hypersecretion of a particular hormone, that hypersecretion of that hormone is going to cause some sort of problem in the body, some sort of clinical manifestation that's indicative of that type of hormone being in large amounts. And on the subsequent slides, I'm going to give you some examples of that include, okay, what's it look like if I have too much growth hormone? Or what's it look like if I have too much prolactin release? To give you just an idea of some of examples of this. Now, what's interesting with this is that sometimes when you have hypersecretion of one type of hormone due to an adenoma, the patient can also end up expressing hyposecretion of other types of hormones from the pituitary. And the reason for that kind of goes back to mass effects again. If that adenoma is putting pressure on nearby pituitary tissue, it kind of makes sense that that particular region of tissue will have more difficulty manufacturing its hormones normally. Growth hormone hyposecretion is particularly common as a type of hyposecretion that can accompany hypersecretion of a different hormone. So as promised, I told you I'd talk to you about a couple of different examples. I'm going to talk about one in which what happens if growth hormone is manufactured in excess. And there are two different disorders that can develop if growth hormone levels are too high. And these are acromegaly and gigantism. And these two conditions arise at different ages. If an individual has not yet stopped growing, in other words, their epiphyseal plates are still open. You'll remember the epiphyseal plates are where we have uh, cartilage present that allows for elongation of long bones such as the femur or the humerus. If those epiphyseal plates have not yet fused, that means there's still an opportunity for lengthening of the bone. And if an individual develops a hypersecretion of growth hormone before their epiphyseal plates fuse, what that means is they'll get overstimulation of those epiphyseal plates, and they will grow taller and taller and taller and taller and taller and taller. And as a result, you can develop a condition called gigantism. Okay? If an adult develops a excess production of growth hormone, well, their epiphyseal plates have already closed off. They've fused. They're done. So I'm not going to be able to influence bone growth at all by hypersecretion of growth hormone. And as a result, the bones are not going to be what respond to hypersecretion of growth hormone. However, there's lots of other tissues in the body that also respond to growth hormone in addition to the bone tissue. Lots of connective tissues, adipose tissue, cartilage, epidermal tissue. They will all respond to growth hormone. You can get generalized organ enlargement as a result of excess growth hormone secretion. That condition is called acromegaly, and that's what this young girl had here when she was 17. She looked fairly normal. As she became an adult and started to have excess growth hormone release, you can see that her facial features have begun to thicken. The cartilage, for example, has continued to grow in her nose. You'll notice her whole face, the connective tissue in her face, has just kind of become more robust. And you can see later on in her life how much more robust all her features are. Even her fingers have thickened and grown larger as a result of the excess growth hormone secretion. Now, up here I have growth hormone and IGF-1. Just so you know, IGF-1 is short for insulin-like growth factor. Insulin-like growth factor. I don't know why my pen is doing this. I apologize. Anyway, you got insulin-like growth factor 1. And IGF-1 is released from the liver when the liver receives a signal of growth hormone. So an insulin-like growth factor 1 is, just as the name implies, it also stimulates further tissue growth. So we get this compounding effect. I get high amounts of growth hormone released from the pituitary gland, and then on top of that, the liver also starts releasing large amounts of IGF-1, and the cumulative effect is this very rapid growth. Another thing that's interesting about this is that, and this relates to the hyperinsulinism, is that growth hormone hypersecretion causes an increased metabolic rate. That should make sense because your cells are being told to divide mitotically. And it tends to impair carbohydrate tolerance, and growth hormone inhibits peripheral glucose uptake, which seems a little strange, but it does. It inhibits peripheral glucose uptake in tissues. And so as a result, we start to get a climb in blood sugar levels. You get hyperglycemia. Now, when a person has long-standing hyperglycemia, that ultimately can cause hyperinsulinism. Remember, the job of insulin is to signal cells to take sugar from the blood and store it. So if sugar levels are really high, it would make sense we'd start pushing out lots of insulin to try to get cells to take that sugar out of the blood and reduce the levels in the blood. If you have long-standing growth hormone release, that means you're going to have long-standing hyperglycemia, which means you're going to have long-standing hyperinsulinism, and over a period of time you can literally exhaust the pancreas's ability to make insulin. And you can also develop a condition wherein the target cells of insulin, they just get so overwhelmed by so much insulin coming at them that they start ignoring it. They stop listening to the insulin signal, and that leads to the development of type 2 diabetes mellitus. And there's actually an entire lecture later on this week that discusses type 2 diabetes and it compares it to type 1, so I'm not going to go into any information about that right now. And again, I already told you that there's a difference between adolescents and adults. Adults can only get acromegaly. Adolescents will get gigantism. Adolescents also get acromegaly because not only do they have bones, they also have connective tissue. So both will respond to the hypersecretion of growth hormone. Now, what's another example of hypersecretion? Well, here's a really common one, prolactinoma. A prolactinoma is basically a adenoma involving cells of the pituitary that are responsible for the manufacture of prolactin. And this is the most commonly seen, clinically, the most commonly seen type of hormonally active tumor. Okay, so this would be one of those functional tumors. And it's usually diagnosed because we see that, of course, if we look at the blood, that there are exceptionally high levels of prolactin present in the blood, far beyond what we would anticipate seeing. Remember, just to let me remind you, prolactin is what induces the development of breast tissue in preparation for milk production, and it also helps to suppress ovarian cycles. So typically, if a woman is going to develop a prolactinoma, you're going to see her have galactorrhea. Galactorrhea, literally, rhea means, think of diarrhea. So it's an excess of, galactorrhea is an excess of milk production. Amenorrhea is no menstrual cycles. And as I said before, one of the things prolactin does is suppress the ovarian cycle. So that makes sense that the woman would not menstruate. For men, it's a little different. In men, we can get oligospermia, which means a greatly reduced amount of sperm production. Men can experience reduced libido. Sometimes they'll have erectile dysfunction. Again, this is the most common type of tumor. It's estimated that somewhere about 30% of all pituitary tumors are ones that manufacture prolactin. This particular picture I like to show you here because it shows you, this is an MRI of a person who has a prolactinoma, and you can see it's right in this area here, and they've actually highlighted it nicely for you over here, and you can see that the prolactinoma is so large that it actually has started to elevate or push up on the optic nerve. So this individual has probably experienced some issues with their sight not being correct, along with all the other problems that I previously mentioned. Now let's go over to the other end of the spectrum. What happens if too little hormone is manufactured? Well, then you're looking at hypopituitarianism. And there are a lot of different things that can cause hypopituitarianism. Obviously, anytime you have death of tissue because of a blocked blood vessel and elimination of blood flow, or what we call infarction, that would certainly kill off tissue and make it so so those cells were no longer available to manufacture a particular hormone. Infections certainly fall into this category. We're not going to worry about TBIs. Sorry. Infections certainly fall into this category. Sometimes when a patient has surgery for other reasons, unfortunately, surgical errors sometimes can damage certain cells. Like, let's say somebody had an adenoma of the pituitary gland and they went in and surgically removed it and accidentally took a little bit of some nearby tissue that was responsible for manufacturing, ACTH. Well, now I'm going to have hyposecretion of ACTH as a result. So there's lots of different possibilities for how hypopituitarianism can arise. I'm going to talk about one example of this called Sheehan Syndrome. Now, Sheehan Syndrome is a condition that's specifically associated with women at the postpartum, meaning right after they've given birth to a baby. So if in pregnancy, the anterior pituitary increases tremendously in size. And that's because it's manufacturing some hormones that help support the pregnancy, and so it enlarges inside. And this is very normal. And when that anterior pituitary increases in size, it continues to be highly vascularized, lots and lots of capillaries. And those capillaries are susceptible to ischemia if the cells near the capillaries are susceptible to ischemia if those capillaries were ever to rupture. Well, in Sheehan syndrome, sometimes some women, after giving birth, will develop a pituitary infarction because they get vasospasm. And that vasospasm occurs in that anterior pituitary, and it's often due to some sort of circulatory collapse because the woman had postpartum bleeding or hemorrhaging. So you get this vasospasm as a result of maybe having excess bleeding at the time of birth. causes this vasospasm to occur. It can lead to pituitary infarction, and that in itself can lead to the development of hypopituitarianism. Now again, signs and symptoms will depend completely on which part of the anterior pituitary is damaged. If I damage the region responsible for growth hormone manufacture, I'm going to get different signs and symptoms than I would if I damage the region responsible for the manufacture of prolactin. So let's take a look here. I'll give you an example. Now, I want to be very clear here that when I was talking about Sheehan Syndrome on the previous page, I was talking about the anterior pituitary. The example of hypopituitarianism I'm going to give you on this slide is relevant to the posterior pituitary. Okay, to the posterior pituitary. So you'll remember the pituitary gland has both the anterior portion and the posterior portion. The posterior portion is responsible for the manufacture of ADH and oxytocin. Diabetes insipidus is a condition wherein the total amount of antidiuretic hormone, or ADH, plummets. It drops off substantially. And this can happen again, like I said on the previous slide, we talked about there's lots of different possible reasons. You can have surgical damage, an infection, you can have an infarction. Lots of different things can occur that lead to the damage of these cells. Once they're damaged and I have reduced or eliminated the amount of ADH released, I'm going to start developing clinical symptoms. And you can actually think for yourself what some of these symptoms would be based on the role that ADH plays in the body. And I would challenge you right now, in fact, I would strongly encourage you right now to take a second, hit pause on this lecture, and sit and think for a second and see if you can't predict some of the symptoms that a patient might experience as a result of having diabetes insipidus. So did you go ahead and pause? I hope you did, because that's the best way to learn, to be actively engaged with the material. If you think about it, antidiuretic hormone's main job is to direct the kidneys to retain water. Okay, so if I am not manufacturing substantial amounts of ADH, obviously I'm going to lose water very readily in the form of urine. So I'm going to get something called polyuria. That means a whole lot of urine being formed, polyuria. And if I'm losing a lot of fluid in the formation of urine, it goes without saying, I'm probably going to be really thirsty. That's polydipsia. Polydipsia. And polydipsia just means excessive thirst. Okay. Now, people can also develop something called hypernatremia, meaning that I'm losing water, but I'm not losing a correlating amount of sodium. Sodium is still present, so if I look at my blood levels of sodium, blood volume, the amount of water in the blood has dropped, but the amount of sodium has remained the same. So relatively speaking, I have too much sodium present. And there are a number of other different types of problems that can also develop, things like you have high plasma osmolality and hydronephrosis, which is a disease we'll learn about in 2-3 weeks when we get to kidneys. But the big three that I just mentioned here are the ones that you should be mostly concerned about. Now, there are two main types of diabetes insipidus, and one type is called the neurogenic form. And in the neurogenic form, that's when you have some sort of damage that has occurred to the posterior pituitary inside of the brain, and that has caused the drop in ADH secretion. That's the most common type. Neurogenic's most common. A less common type is the nephrogenic kind, and you can tell just by the name here, nephrogenic. This relates to a problem with the kidneys. And in this case, nephrogenic usually occurs when somebody's in end-stage renal failure and their cells of their kidneys are just shutting down, and they are no longer responding to any stimulus, including they no longer respond to ADH signals from the posterior pituitary. And so as a result, the kidneys just start losing copious amounts of fluid even in the face of a functional posterior pituitary gland telling it not to do that. Okay, that's enough on the pituitary gland. Next up is the thyroid and parathyroid.